Good morning, everyone. Thank you to the moderators for the opportunity to speak. So I've been tasked with endoscopic management of anastomotic bleeding. I have no disclosures. So I'd like to start with a scenario. This may be giving you a visceral reaction, pun intended, like it does to me. You have a 44-year-old female who's just undergone an uncomplicated Roux-en-Y gastric bypass the day before, and you're rounding on her. You notice she's mildly tachycardic but normotensive. She's alert and speaking to you, and she reports that she had a bowel movement with blood and mixed stool this morning. You check her lab work, and her hematocrit has dropped by 3 points. So what would you do? Most of us would probably put her in a monitored setting, trend her CBCs, and transfuse as necessary and hope that it stops on its own. So now let's change the scenario. Same patient, but when you see her, she's tachycardic, hypotensive, says she's had multiple bloody bowel movements this morning. How will that change your management? How will you intervene? So you're all here at an endoscopy talk. Let's assume you're all going to take her for an emergent upper endoscopy, and you find this once you're in the operating room. Do you know what's at your disposal? So I want to pose a few questions. The first one, we've kind of already answered. If you suspect intraluminal bleeding, what should you do? Should you sit on it or should you intervene? And the answer is it really depends, and we're going to go over an algorithm in a moment. Most of these will stop on their own. Bleeding happens early. Is it safe to scope? So the short answer is yes. There's several retrospective studies showing that there's no risk of perforation or any other complications if you scope early, and that's for upper or lower anastomoses. And finally, what should you be telling the OR to grab off of the shelf? So the majority of your anastomotic bleeding will occur within the first few postoperative days, even the first few post-op hours, evidenced by hematemesis, hematochezia, melena, and even SBO. So if they have evidence of mild bleeding, I think following the pathway down the left side of the screen is probably what most of us would do. But if they have evidence of moderate to severe GI bleeding, in other words, dropping their hematocrit despite transfusions or hemodynamically unstable, or rebleed after initially stopping, in other words, the same indications that would lead you to take the patient for a surgical intervention, you should be considering endoscopy. Here are some practical considerations for managing bleed endoscopically. I recommend that you perform it under general anesthesia in the operating room, especially in the case of an upper GI bleed, because they are a high aspiration risk. And you can also have the team in the operating room set up laparoscopic equipment as a bailout. I always use CO2 for any therapeutic endoscopy cases because they can take longer than a diagnostic, and they do require more insufflation. But that being said, I would try to minimize insufflation, especially if this is a fresh anastomosis that you're dealing with. And I would use a distal attachment cap if you have one available, and that just puts space between the camera and your target tissue. So visualization can be difficult if you have significant intraluminal clot. If you're going after an upper GI bleed and you do feel comfortable with if you have a fresh anastomosis, putting down an NG tube or even an E-wall tube, which I've never seen one before in person, but I know they exist, before the procedure can help you evacuate some of that clot. And for either upper or lower GI bleeding, I would recommend using a foot pedal irrigator system. It gives you aggressive irrigation. You can thin out the clotted blood. That makes it easier for suctioning. And always have a large tip, 50-60 cc slip tip syringe on standby for flushing, because you can get clotted blood in the tip of your working channel, and you can have that handy to flush out your working channel. So as you're rolling to the operating room, what factors do you need to be thinking about? The first is location. Where is it? Is it even something I can reach with a scope? Then what equipment is available? And as you will see, there are multiple endoscopic techniques that you can employ to treat GI bleeding. Which one will be effective and most safe for treating an anastomosis? So location is key. You will only be able to treat a bleeding anastomosis that you're able to reach. For reference, the average mouth to distal stomach is approximately 70 centimeters. The average anus to cecum length is 150 centimeters. Of note, an additional strategy for reaching any difficult distal area is to consider a hybrid approach. So you can place a 5mm camera port and a couple of 5mm working ports, and you can guide an endoscope through the bowel. And for example, to reach a bleeding jejunojejunostomy, you can easily feed a 120 centimeter rouleum over the scope to still be able to treat it intraluminally. Here's a helpful guide of working lengths of common scopes and working channel diameters, which is something helpful when thinking about where you need to reach and what you'd like to do. The standard adult gastroscope is around 100 centimeters, and a colonoscope is around 150 centimeters. And most equipment that we're going to discuss today will fit down the smallest 2.8 millimeter channel of an adult scope. There are some larger coagulation catheters that will only fit down bigger diameters. My point in saying this is that you just need to confirm before opening anything that it will fit the length and the diameter of your working channel. So I'm going to split the techniques that I'm going to talk about today into two broader categories, those that require heat and those that do not. The obvious warning here is that any heat comes with risk of perforation, so it's not a good first choice for any fresh anastomotic bleed. As a side note, most of the literature on efficacy of endoscopic treatment of GI bleeding comes from things like ulcer disease, diverticular disease, and variceal bleeds. Little evidence is published regarding anastomoses specifically. So talking first about coagulation, this includes monopolar and bipolar cautery probes, which do require contact with tissue, as well as argon plasma coagulation, which is a non-contact thermal method. On the screen left, you see the monopolar hemostatic grasper. The advantage to this is that you can pinch and lift away from healthy tissue, so you do get a little bit of control of the thermal spread. In the middle is the bipolar heater probe. You do have to put this in direct contact with the tissue and burn for about 8 to 10 seconds, and there's really little control regarding the depth of tissue penetration. The argon plasma coagulation catheter is good for superficial raw surface bleeding. Depending on the setting that you're putting the generator on, it only burns the mucosal surface. That's obviously not the usual case with a bleeding anastomosis. Usually you have a single bleeding vessel. So in conclusion, these will not likely be your first choices for a fresh anastomotic bleed, but you can keep them in your armamentarium for perhaps late bleeds or things like marginal ulcers. Next, I'll talk about injection of dilute epinephrine. So by dilution I mean about 1 to 10,000 or 1 to 20,000. It's the oldest endoscopic hemostasis method, with typical injection volumes recommended at 15 to 25 mLs for the upper GI tract and less than 10 for the lower GI tract. There are no specific recommendations for anastomotic bleeding. Adverse events of injection usually are infrequent but include perforation or tissue ischemia. So there is just a cautionary, if you're thinking about using this in a fresh anastomosis, you're going to potentially compromise the blood supply. And it's also not recommended as a monotherapy because there is a high risk of rebleed after this. So you do want to, if you're going to use this, let's say with a late bleed, more than 30 days out of your anastomosis, you want to also use it in conjunction with another modality. So finally, hemostatic spray. It was approved in the U.S. around 2018, and there are two brands that I know of on the market, Hemospray and Endoclot. It requires minimal training, so that's why this is really of interest to a lot of people. It's very easy to apply to focal or diffuse areas in all locations of the GI tract, and it doesn't cause significant tissue injury. So what it is, it's an inorganic compound that doesn't attach to the mucosa. It only affects areas of active bleeding. So as a note, you have to have active bleeding at the time of application. The powder absorbs water molecules up to 30 to 40 times its dry weight, which causes this powder to swell and causes a physical barrier. And it also is thought to concentrate clotting factors at the site of bleeding with subsequent clot formation. So it's administered through this catheter, which goes down your working channel. So basically, you just point and have your assistant pull the trigger of this pressurized carbon dioxide canistered handle, and that ejects the powder onto the site. You shouldn't aspirate while you're applying this powder because it could clog the working channel. And it's best to use this, again, in conjunction with something else, another modality, because it only lasts for about 12 to 24 hours. So this is good for initial control of bleeding if you're having a lot of issues, getting visualization or controlling the bleed initially to go on to another modality. And this is probably the most important takeaway from this talk is mechanical closure with clips. Clipping is probably your best bet and should be your first choice for hemostasis with a fresh anastomosis or even a late anastomosis bleed. The two broad categories of clips are through the scope clips, also called hemoclips, or over the scope clips. And hemoclips are small, thin, and can be used for superficial bleeding, especially if there's a visible vessel. They're very easy to fire. They do require the use of an assistant to fire them. And there are newer style clips which also have teeth, allowing you to grab a larger bite of tissue because you can draw tissue over without slippage. So these Through the scope clips can also, of note, be pulled off with a grasper if you need. And here you see two kind of techniques on the right. The first top box is kind of zipping up that bleeding anastomosis with multiple clips. And the bottom, you can see a visible single vessel, so they've ligated the inflow and the outflow of that vessel. Here's the over-the-scope clip, which you've already heard about several times, but just to go into a little more detail, the over-the-scope clip is larger, it grabs more tissue, whereas the through-the-scope will close the mucosa. This will close full thickness in theory, but it does require some prior knowledge of how to load it. It has multiple indications, including perforations, leaks, fistulas, stents, fixations, and non-variceal upper GI bleeds. Or lower GI bleed. So here's what it looks like on the right once it's fired onto tissue. This is very difficult to take off if you misfire because it requires a separate piece of equipment that you buy from Ovesco to break the joint to remove it, so it's kind of clunky. The company makes 3 different versions in varying sizes, which you can see on the bottom, and if you're going for hemostasis, you're going to be using the A or the T version because that's indicated for compression, whereas the GC is for closure of gastric defects. So this is, again, good for things like ulcer bleeding, diverticular bleeding. For most anastomotic bleeding situations, your first choice is probably going to be through the scope just because it's a little bit easier to handle. But if it's a very, unruly bleed and you're having trouble getting control and you just want to kind of grab a bunch of tissue, this would be a good option. And one side note is that if you are firing clips, the patient continues to bleed and you're considering going back to the operating room and have to revise an anastomosis, you do not want to fire a stapler across any of these clips. So in conclusion, the main takeaway points I'd drive home is that it is safe to perform endoscopy early in the postoperative course after anastomosis creation. The first choice should be clipping the anastomosis at the site of bleeding for early intraluminal bleeds, so within the first couple days when you have a fresh anastomosis. And for late bleeds, you need to be prepared for multiple hemostatic modalities. Thank you, and I'll take any questions.